everyone. It's 2 o'clock, so we'll go ahead and get started. Just to cover a couple of housekeeping items before we get started with the session today. Closed captioning is available for today's session, and it's available through the link that is provided into the chat box. The session is being recorded and will be available on the NNLM YouTube channel in a few weeks. Feel free to chat your questions throughout the session. Just make sure that you chat those to all participants, and we'll stop at a couple points and answer them throughout, or we'll answer them at the end. Participants in this class today are eligible for 0.75 CHES CECH, and you can claim that through the evaluation that will automatically open up when you close out of this WebEx session today. And after you complete the evaluation, it will ask you to enter your name and CHES ID number. And also just generally, if you're not seeking CE today, we do still really appreciate your feedback. So when that evaluation opens up, if you don't want continuing education, please click no and let us know what you thought about today's session. And now I'd like to introduce our guest speaker for today. Robert Martiniano is the Senior Program Manager at the Center for Health Workforce Studies, which he joined in 2001. Dr. Martiniano has an extensive background in health workforce research and program management, and he is the lead staff on a number of center projects at the center relating to federal shortage designations and the healthcare workforce. Dr. Martiniano supervises data analysis on various healthcare professions, on survey design, and on Medicaid access and utilization of healthcare services. He's worked with many diverse communities, agencies, and membership organizations on developing community health assessments. These assessments identify provider and workforce shortages based on the healthcare delivery system and the health of the population, and measure the impact of new models of care on the healthcare workforce, incorporating the development of emerging workforce titles. Dr. Martiniano has a strong background in evaluation design using quantitative, qualitative, and mixed research design methods, and is an adjunct professor at the Sage College's School of Management, teaching courses in Introduction to Health Systems, Strategic Planning, and Comparative Health Systems. And with that, I'll go ahead and turn it over to our guest speaker.
Thank you, and good afternoon, everybody. You can hear me, right?
Yep.
Okay. So, as Erin said, we're going to talk about community needs assessment. I want to spend time on kind of going over concepts and kind of getting into some of the weeds around the data, because I think, you know, I think for community needs assessment, there's so much data that we can pull in that you really have to learn how to tell the story with that data to understand what message you're trying to get across and where you're heading. So essentially, Erin gave an introduction of who I am, and I'm from the Center for Health Workforce Studies. As she indicated, I've worked with a number of counties and hospitals in New York on doing community needs assessment over the last 3 cycles. So as part of the 990 requirements for non-for-profit hospitals, they were required to do new needs assessment in New York. The Department of Health told them basically to work with the counties, so the counties and the hospitals started to work together. And that's where I got involved. Today's webinar, essentially we're going to go over these things. We're going to briefly talk about what is a community assessment, what it's needed for, how you plan for one. As I said, I want to talk about data issues, both from a primary data collection point of view and a secondary data point of view. And then finally, if we have time, given this 45 minutes, I want to give a couple of ways that you can prioritize findings. Because most of the time when you do these, you're going to find 3 or 4 things that you really say, you know, are issues in our community, and given the limited resources, especially now, you're going to have to make a decision on what you need to work on and what you can't. Okay. And as Erin said, we will stop at certain points to ask questions. Also, if you have a clarifying question, just send it through. Erin's going to be monitoring the chat box, and if it's a clarifying question on a slide, she'll interrupt me and just say, can you explain this further? So it's not a big deal. I want to try to make this as interactive as possible. So what are community needs assessment? So, as it implies, it's really an assessment of the community, and we're going to talk about how you define a community. But it's an assessment of the population, of the resources in that community, of the services being provided. And when we talk about services, we're talking about both healthcare and non-healthcare. As we more and more we talk about the social determinants of health in healthcare, we need to think about the social service agencies that are addressing some of those social determinants of health. You can't really talk about diabetes to a patient when they don't have access to good food. You can't talk about, fall prevention in public health when there's nobody to go check your house and make it more handicapped accessible. So, we have to have that broader discussion on community needs assessment, and then, of course, healthcare statuses and healthcare outcomes. Well, I want to try to make this as broad as possible. While I'm going to give a lot of examples in healthcare, you could do this around anything. You could do this around education. You could do this around social services. As you look at what your issue is, then you have to think about what data set you need to use. And ultimately, a community needs assessment will help identify community priorities and then focus funding on those priorities. So for most of us, and I've been on the receiving end of this, most of us do community needs assessment because it's required by either our government or a funder. We're getting money to do X, Y, and Z, and they want to make sure that we're prioritizing our work. For some of us, especially those that work in hospitals, community health clinics, and other type services like that, we may be doing it not so much because we're required to, but because we're looking to expand services. We're looking to see, can we increase our labor and delivery? Can we do more in primary care? Can we address a certain population? That's why, again, that's why we do community needs assessment. Why are they important? They identify potential problems. And I think, one of the things that I'd like to talk about is stakeholder, and we'll talk about this, like getting stakeholders involved, not only for the community needs assessment, but for other things, because the more you can work with community providers in your area, the more you're going to be able to work on solutions together. And again, other things for community needs assessment is identifying potential solutions and then creating a guide for implementing those solutions. And we'll go into, one of the things I do want to talk about is, I'll go into talking about how we define our service area. Okay, so let's talk about planning for, okay, so what are the important parts of community needs assessment? Again, as I talked about, I think identifying the community stakeholders is so important in terms of, and we'll talk about this, in terms of getting input to identify your problems, in helping identify or helping understand the data you look at, interpreting, and also contextualizing it. And I'm going to talk a little about that too. So when I was working in some northern areas of New York a number of years ago doing community needs assessment, there was, we were doing county by county assessments, and there was an increase in E. coli in one of the counties. And so, as a researcher, I'm going, okay, so is this a problem? Is this not a problem? Well, what happened was, and so as we started talking to stakeholders, they said there was a county fair, and most of us in the Northeast have these all the time, and there was an E. coli outbreak. So we saw this jump for this one time only, and it goes away. But those are the things you need to understand to contextualize your data. So it's not just a persistent problem, it's a one-time problem, or it's an outlier that you don't need to address. So again, I think it's important that your stakeholders help not only look at the data, analyze it, prioritize it, but contextualize it at some point. So what do we mean by stakeholders? My belief is the stakeholders should be as broad as possible. You should get everybody and anybody in your community to give input, because ultimately they're going to be the people that are going to help you implement your priorities and possibly evaluate your priorities. As I said, it also is a good way to build relationships as you have to do other public health or other social service interventions. You're already working with these people, these organizations, these people. It's going to be a lot easier to do other things if you already have these relationships. You know, a number of years ago, I actually had done some work in the North Country of New York, which is pretty much north of Albany. And on one side, we had a meeting, we kind of talked about community data, and everybody got together and worked together. On the other side, it was a lot more problematic because they had never worked together before. And you could see the difference. You could see them in their silos trying to understand how to bring in education, how to bring in healthcare, how to bring in social services, and they've never done it before. And I think building, you know, relationships and getting the stakeholders involved is going to help immensely, not only for this project, but many projects down the road. So as I said, you know, once you get the stakeholders, or maybe before you get the stakeholders, you need to define your community. In a lot of cases, like in New York, your community, or at least your community needs assessment, are county level. You know, so the Department of Health is telling you, some other state agencies telling you need to do assessment at the community or at county level. But for hospitals, for community health centers, it may be a service area that's either less than a county, multiple townships, or may span multiple counties depending on the service. You know, what I've said before for especially hospitals, service areas are going to vary by the type of service you provide. So if you're talking primary care in the middle of an inner city, you may be talking blocks or a number of blocks. But if you're talking in upstate New York, you're talking about transplants, you're talking about other large services, you're talking about a much broader service area. So again, service areas within an organization may vary by the type of service being provided, and that's not a bad thing. It also may be population-based. So within a geographic area, you may want to focus on a population. Again, homeless, HIV/AIDS, migrant farm workers, lower income, people are uninsured. You may even, like if you're thinking about a community needs assessment for labor and delivery, you may want to focus on women of childbearing age. So again, as you think about your service, as you think about what you're trying to do, think about either the geographic area and or the population you're trying to serve. And again, the geographic area and the populations can vary. So as you think about defining the community, you know, think about political boundaries, cities, towns, counties. I know, especially in the South and some of the larger states, larger from a geographic point of view, their counties are almost like our Northeast towns. So their health departments or their health districts are a combination of towns. So again, you've got to think about how you're going to define your community when you're doing community needs assessment. If you're in an urban area like New York City or Boston, Philadelphia, you may want to think about some historical neighborhoods, because generally those neighborhoods will have like populations based on race, ethnicity, based on culture or nationality, based on poverty and other things. And even within that, you may want to look at certain census tracts or certain, again, neighborhoods based on again, population, poverty, and other things that make sense. And again, you may want to define it based on a hospital service area or even a government service area. I know in New York State, the Office of Mental Health defined the mental health service areas around certain hospitals. So again, service areas are going to vary depending on your funder, depending on who's providing services and who's requesting your community needs assessment. So I want to take a break and wonder if anybody's got any questions. And again, send them to the chat box. Okay.
Looks like we have one. It says, health departments complete community health assessments. Is there a distinction between a health assessment and a needs assessment?
No, not at all. I think it's just terminology. I mean, I'm trying to be broader by talking about needs assessment again, because you could do it around education, you could do it around social services, you could do it around veteran services. Again, I think I don't even remember what New York State DOH calls it, but it's essentially the same thing, and you're going to go through the same process.
Thanks. And so what you're saying is that someone might narrow in on a topic if they already know what they want to look at, or a different organization, depending on needs, might be looking at several different needs.
Yes. And again, even with the county needs assessment for the Department of Health, when I was working with the counties, there were a number of different areas that they focus on: maternal and child health, environmental, HIV, AIDS. I don't remember. There had to be 10 or 12 of them, their focus areas. And so, you know, state by state or county by county, there are going to be multiple areas you're going to look at. And part of, as you're looking at those areas, is telling that data story. So this kind of fits in that As you start collecting data, you're going to want to start weaving that data into a story. So, Erin, are we ready to go to the next one?
Yes, thanks.
Okay, you're welcome. So as you think about your data, the first thing you want to do is figure out the best way to collect the data you're going to need. And part of that is understanding what data you need, what data you have, and if you don't have it, where can you collect it? I think one of the biggest problems, especially in healthcare, is that when we're using data to do these community needs assessment or community health assessments, the data is all over the place. We're using population data from some sources. We're using healthcare data from multiple sources, either within the state or outside of the state. We're using education sources. And as researchers or as public health officials, we're having to bring this data together, and it's not easy. So it can be problematic, and we will go through some of the different types of data that you could use. But as you start looking at the data, what does the data tell me? What doesn't the data tell me? Does it make sense for my community? So in New York, there are certain data indicators that are really focused on the urban population in New York City. So when I start looking at data for upstate New York, I may decide that I don't really want to address a specific type of data because it doesn't make sense for my upstate population. And the reverse would be true if I was in New York City. There's certain, you know, transportation being one of them. In New York City, public transportation is a much bigger issue, and I may want to use that as a data indicator. In upstate New York, where virtually everybody has a car because you can't get any place without one, it's not such an issue, and it may not be a data indicator that I want to use. So again, as you think about the data, as you think about your community, does the data make sense? Where can I get it from? And again, as I gave the example before, how can I contextualize that data and explain various blips in that data so it makes sense, so I'm not reacting to something that's a one-time only thing. So how do you tell the data story? And I don't want to make this a research class, but essentially you're looking at primary data that you may have to collect yourself, or secondary data that someone else has collected that you can use. In either case, you need to think about how you're going to compare that data to a benchmark. Are you in your county or your service area above or below that benchmark? Is it something you need to address? if you're at 15%, let's say for smoking, and everybody else is around 30% around your area, is it something you want to address? Now, you may say yes because smoking is bad in general, but you may say for a number of reasons it's not something I really need to address. If you start looking at let's say teen pregnancy or something, and you see there's small numbers, it may be an issue in your county or your service area, but you may realize that it's not a big enough issue when you start comparing it to other counties around you, other service areas around your state. So again, you always want to think about the benchmarks that you're identifying and how you're going to draw judgments about your data based on those benchmarks. And then finally, as you think about your data, drawing conclusions and then prioritizing your results is so important. What is your data telling you? What direction is it sending you in to actually make some decisions? So, kind of in summary, as you think about your story and think about your data, is it clear and concise? Did it weave a story? Did it help you prioritize your work? And then I think the second thing is, as you start telling your story and looking at your data, is it something that can be addressed? Is it something that your organization has the ability to make changes around? So, for example, if drinking, or let's say if smoking is a huge issue, and you decide you want to increase the cigarette tax, in New York State, a county can't do that. Only the state can do that. So you start realizing that there are problems that you can address, problems you can address, and you need to think about how within your organization those problems fit in. And finally, resources. Are there resources available already addressing the problem? So if maternal and child health is a problem, but New York State, or your state in general, is putting in a ton of money to address it, do you need to? Or can you focus your resources on something that you don't have as much money for? One of the things that when I talk about weaving a story, I'll give an example. New York State at one point, when they were doing their community needs assessment, looked at motor vehicle accidents. But it was the only motor vehicle indicator they had. And as I started collecting data, I actually went to other places and looked at pedestrian accidents, speeding, other motor vehicle issues. So again, to create that story, because if motor vehicle accidents really has to do with speeding, is it a public health issue, or is it something you should be working with your sheriff's office to deal with? So again, you're going to want to be looking at these issues and try to understand, again, whether you should be doing it, whether you need to pull in somebody else to help you do it, and whether the resources are there. Okay. So another break. Do we have questions, Erin?
Yeah. I think one question you may have already kind of answered on the following slide, but somebody had asked what strategies can be used to address data that is not close to the benchmark. Did you have other comments on that?
I guess it really depends. I mean, that comes down to prioritization. If it's not, so when I was doing community assessments, I actually created quartiles and tried to judge how far away from the benchmark my indicator was to see how severe it was. So if it was just a little away, it's not so severe. If it was in the fourth quarter away, then it might be more severe. But then, again, I'm thinking, all right, even if it's severe, are other people addressing it? Are there other social service agencies or healthcare agencies that are spending resources and money to address this? So you kind of balance, how severe is it? How many people does it affect? If you've got an indicator that's really high, but it only affects 2 or 3 people, because that's just the indicator, whatever it is, a very specific and esoteric childhood disease, it may not be worth it. You may have a high indicator, but given the resources out there and the number of people it affects, you may say, it's not worth my resources. Because most of the time, the resources that we are using are public resources. And we've got to try to figure out how to focus those money on what's the most important things.
Great. And another question somebody had asked was, what would be a projected timeline from start to completion of an assessment?
If primary, I'd say 6 to 9 months, given, especially if you're doing primary data collection, and especially if you're bringing in stakeholders, which you should be doing, because you're going to want to, sit down with them, talk about what data needs to be collected, collect the data, analyze it, and then go back into the community to analyze that data and to contextualize that data. People who do it and I've had people come to me and try to do it in a shorter time period. You're not going to do primary data collection. You're just going to do secondary data, and you may not get all the data that you need.
Great, thank you. I think that's all we had for now for questions.
Okay. So this is going to be kind of the real boring part where I'm really going to start just talking about different data that you should be thinking about. But for your service area, and here they're listed, I'm not going to just read them. One of the things I talked about was your organization and what you can and cannot do. Just remember, as you look at your mission statement, this is something you can address. And as you think about organizations in general, either the organization you're working for or one you may be volunteering for after work, you always want to look at a mission statement and what their mission is and what you're trying to do. As I think about the service area, and I'm going to pick out a few of these, and I actually had, when Aaron and I went over these slides, I had actually pulled out a number of them, but like housing stock, why is that important? Well, the age of housing is important when you think about lead. So in 1978, the federal government took lead out of paint. And so if your house is older than that, there's potential that there's still lead either in the paint or in the ground from where paint got scraped off. And obviously there are developmental issues with children with that, so you want to think about this. How that's ownership and seasonal rentals. What does that mean? Well, if housing stock ownership, if you've got low ownership but a lot of rentals, you probably have a more transient population. And again, that's a generalization, but it's generally true. And what you want to think about is how can I make sure that these people have a usual source of care when you've got a lot of movement within your ownership. Same thing with seasonal rentals. You may have a lot of houses. So we have, but they're not occupied generally. We have a county, a very small county that has a lot of seasonal rentals. So only about a third of the structures are occupied at any one time. As I talked about access to care, we talked a little about public transportation. How did that impact your ability of a client or a patient to get one place to another to get your service? And I kind of tie in jobs, employment, and type of work and employers together, because they're all intertwined in terms of understanding your population. So, for example, if you have a large farming community, you may have people that are with high exposure to contaminants. Moderate to low income, there's going to be an issue with insurance or having commercial insurance, especially if it's a small private farm. And in many of these rural areas, high number of ED visits because of farm accidents, tractors and balers and all that stuff. So again, as you think about, again, your service area, it starts telling a story on the population that you are dealing with. Again, other things in your service area, and again, unfortunately, I did focus a little on healthcare, but you can do social services, education, whatnot. So who are the providers? Where are they located? What are the bricks and mortars? And bricks and mortars being the health centers, the hospitals, the nursing homes, and home health care. But you could think about this in the same way in social services. Where are your food pantries? Where are your veterans outpatient clinics? Where are your social service clinics? And homeless and housing. So again, you want to think broadly. You want to think about your service area and try to understand as much as possible who's doing what to whom. So I'll just give a brief stop right here. Does anybody have any questions about data? Again, I just kind of gave a few examples.
Robert, I don't know if you prefer to answer this a little later because I know you're going to talk about this, but somebody had asked about how to involve stakeholders in analyzing the data. Or do you want to wait and address that at the end?
I can do that now.
Okay.
I think what you do, you start right at the beginning before when you first start thinking about your data collection, bring them into a room, say, I want you involved, and go from A to Z with them. Start with, let's talk about surveying you or surveying providers in the community. Let's talk about data collection. Let's talk about the process for making decisions. Let's talk about all these things. Because again, I think what the worst thing you can do is go through it all and then bring them in and say, all right, tell us how you feel about the data. And I go, that data doesn't make sense to me. What you want to do is get them involved right from the beginning. And again, I think it helps not only with this process, but any process going forward in terms of trying to solve community problems.
Thanks. And have you ever had issues, they said getting data from a stakeholder, or I guess involving them?
Yes. Oh, yeah. Because some, they may not have worked with you before. They may be, unfortunately, even within healthcare and within our communities, people work in silos. There's no way around that. And at times, people may not be willing to share for a number of reasons. And it's just, you just have to kind of roll with that flow and try to understand and try to get them the best, get them involved the best you can. Again, I think once people start seeing that you're working with them, I think it perpetuates and builds. But it takes a long time to get that to happen.
Right. Okay, thanks.
You're welcome. So I want to talk about primary data collection again. I don't want to go, again, I don't want to make this a methods class, but I do want to kind of talk about if you don't have the data, how you can do it. Qualitative is case studies, focus groups, and interviews. Observation is also a primary data collection, but it's really not used for needs assessments, more used for watching work behaviors or time trials or things like that at time of work. The same thing with quantitative data. Surveys are the best way. Journals you can do some quantitative analysis with, but again, generally it's not used for community needs assessment. Journals are really good if you're trying to understand, you ask somebody, all right, I want you to jot down everything you've eaten for 2 weeks. So every time you have a meal or a snack, you write it down. Or when you exercise or what TV programs you watch. It's really good for that. It's not so good for trying to understand the community needs assessment. The thing about case studies, focus groups, and interviews, they're great, but you generally have a small group of people doing it. So I would argue that sometimes you could actually use it as a starting point in your community needs assessment to kind of understand some of the issues as you to build your survey around. When we've done it at the center, we'll do that. We'll interview people. We've done a number of telehealth studies. And so what we do, we'll do some case studies or interviews first to understand the issues and then work on creating our survey questions. One of the things that we have done in the North Country is actually interview organizations to understand who they are and what they do. And that you needed a survey for. And so, what you do, what your service area are, services provided, population served, your funding levels, and finally, most importantly, what are your priorities? Even if it's an education institution, a high school or a community college, they may understand the priorities because they may be seeing it, maybe not addressing it, but they may be seeing people come in with poor nutrition or with other issues that you as a county or as you as a community may want to address. And they may also understand the barriers for addressing priorities. And again, it's just, the last time I did a full-blown community needs assessment in the North Country, not only did we collect data, but we worked on doing this community assessment of providers to understand all these issues and more. So not only were they part of the review committees and part of the process, we also had them help us with understanding the service. So we talked a little about primary data. I want to talk a little about secondary data. Secondary data is data that someone else has collected that you would use, and there's a ton of it out there. There's no doubt about it. But the first question is, what level of geography is the data being presented at? If you're trying to do sub-county analysis and the only data that's available is county analysis, it's going to be really difficult to understand your community. And unfortunately, the examples I give are all New York State, but Albany County, which is Albany is the capital of New York State. It's got a very urban area and it's got a very rural area. So if I looked at the county-wide, I would mix things. I would miss issues going on in the rural areas because it's overwhelmed. Same thing with Boston or Philadelphia or New York City, that if I look at it as a whole, then I'm going to miss subpopulations and sub-areas that are having problems. Again, you want to think about your level of your geography. It doesn't make sense. The other thing is, in a large part, data is collected at whatever level of geography they collect it at, because it's a matter of convenience. That's just the way it's done, and it may not be useful for you. As you think about the data, secondary data, is the question they ask appropriate and match the question you ask? It may be slightly different. It may not get to the answer that you totally wanted to get it to. As you think about the data, is it the population versus a sample? So, for example, with American Community Survey data, it's a sample, but if you look at the census data every 10 years, it's a population, but the census data only gives you a few data elements. You have to think about that. How's the data being presented? Rates, percentages, ratios, things like that you need to understand, because if in one place it's per 10,000, let's say, number of cases per 10,000, another case it's a number of cases per 100,000, it's going to be very difficult to put those two, and you don't think about it, you're going to try to put those two counties together, it may mask a real problem. And I just want to stop to say that on the NNLM website, there's a webinar that Aaron did on health statistics, and I would go look at that to just kind of understand how to deal with the secondary data you're looking at. And also, what's the data being collected? So right now, as we're heading into the November election, we see all these polls. They, is it a registered voter versus a likely voter? Because sometimes you can get two different statistics and two different outcomes. How big is the margin of error? If generally they're all, most of the surveys that are done are within 3%, but if you start getting 5%, 7%, the results are too fluid and may not be as accurate as you want. Just some secondary data, demographics, and age, and again, I won't go over these. The one thing, again, if you're thinking about maternal issues, maternal health issues, you may want to look at women ages 15 to 44, because that's the age they talk about things in terms of labor and delivery and potential childbearing years. Health statistics, again, behaviors like drinking or smoking, hospitalizations for falls, cancer, for heart conditions, for every kind of surgery. Status, do you have asthma? Do you have diabetes? Do you have hypertension? Do you have high cholesterol? Things like that. Because you're going to, if you've got an older population, you're going to be taking some of the demographic data and combining it with some of your health status data and hospitalizations to start talking about your older population. And then finally, vital records, deaths and births. Education, so college graduations, and that's one of the things that I focus on because of my work around the healthcare workforce. But if you're talking about a population that does not, a lot of people have not graduated from high school, you may be talking about a population that both low-income jobs, lack of health insurance, but it starts going into the story. And a lot of times that I also use things like limited English proficiency and tie that to some of the demographic data I get from the American Community Survey that start thinking about my population and the use of the English language and literacy in general. And then finally, when I talk about poverty, I want to talk about, I'll use the American Community Survey data again, but I also look at the percent on free or reduced lunch in the school district. Again, it gives me a fuller story of my population and the poverty issues around that population. Okay. So, unfortunately, Erin, we've got about 3 minutes. So,
yeah,
I do have some slides on prioritizing. You can look at them. If you have questions, you can email me or call me. There's just a couple of different examples and ways to prioritize your findings to start understanding what solutions you or where you want to go with your funding. The other thing is, I was
going to say, for anybody who didn't see, there's a link to all of Robert's slides in the chat box, and when you open that up, it'll be a PDF that you can download and save. There's a link in the chat box for you to access the slides. We also will post a, I'll send the slides when I send the YouTube video as well, and there's also, we're going to share a handout of more information. Go ahead, Robert.
That's all right. I'm sorry. We're talking over each other. And also at the end, I did put a couple of links to other resources. I know Kansas University has a whole toolbox on community assessments. There are a lot of community issues in general, including community needs assessment. The CDC does. Community action partnerships do, as well as actually the Center for Health Workforce Studies has done a little work around community needs assessment. So again, they all can give you more or less information on how to do this. Again, I didn't want to stop, but any questions?
Yeah, and for those of you who are logging off, because I'll answer the questions that we have so far. But if you are logging off, I'll let you know that you can get CHES credit just by answering the evaluation that will automatically open when you close out of the WebEx. But for those of you who had already dropped a question in the chat box, somebody said, any ideas of how to collect primary or secondary data about our population's perceptions of face-to-face interactions?
That would definitely be a survey question. That'd have to be surveys. There are questions out there about attitudinal questions. And, you know, what I generally do is when I have to write a survey, first thing I'll do is try to see if someone else has done it and see if there are questions already out there. And I believe there are some questions out there on face-to-face interaction and perceptions around that. You just have to do it. Work with some researchers at your local university to try to best ask questions. I think also in that case, it might be one where I want to do some interviews and some focus groups on providers to try to understand what the issues are as I develop my questions. And that's just off the top of my head.
Okay. And I'll just ask one more because we're at 2:45, but any comments on pros and cons for working with raw data sets from another agency?
Say that again.
Any comments on the pros and cons for working with raw data sets from another agency?
I'm sorry, can you repeat that? I kind of lost you for a second.
Oh, sure, sorry. Any comments on pros and cons for working with raw data sets from another agency?
Oh, yeah, totally. And we do a lot of work at the center with the secondary data. Understand how they collect it, understand their questions, understand their level of geography, look at their survey instrument to make sure they're asking the questions you want to ask. understand how they clean their data. One of the things we're doing at the center is when we're cleaning our primary data collection, we're creating a kind of a TA manual to walk people through it so that they understand what we're doing, so they understand. Again, secondary data is not easy. You've got to understand how they collect it, what questions they ask, because if you don't, you're going to be using data that may not make sense to you ultimately, or may not answer your question. Yeah, so you got to be really careful and really work on understanding the issues around their data.
Great, thanks. And we'll go ahead and wrap up now. Thanks, Robert, so much for answering everyone's questions and for providing the slides for everybody to access again, to read over for their own reference. I will send a recording of today's session out to everybody who is registered along with the slides and the handouts. So you'll get those if you didn't access them in the chat, but otherwise there are links in the chat for you to access both of those handouts. And if you have any questions, Robert, if you want to scroll forward to the end just for our contact information, you'll see both mine and Robert's contact information on the screen here.
That's just fine, yep.
Yep.
There's Aaron's and there's mine.
Great. And anyone, like I said, who's interested in CHES CE, there will be an evaluation at the end of the session. When you leave WebEx, it will automatically open up. And if you have any issues or questions with that, please send me an email. But other than that, we thank you all so much for coming. This is our first session of our public health webinar series. So we'll have another session in 2 months from 2 to 2:45 Eastern time, and you'll see that posted on our website.
Thank you, everybody.
So much. Thank you again, Robert, for coming to share your knowledge with us.
Thanks for watching. This video was produced by the network of the National Library of Medicine. Select the circular channel icon to subscribe to our channel, or select a video thumbnail to watch another video from the channel.